And at this time, I'd like to invite Elisa Arzpaco-Chaga, the Vice President of Clinical Affairs and Workforce at the American Hospital Association, to come to the podium and lead a Q&A for the panels 1 and 2, and invite the panelists from the previous group to come up as well.
Thanks so much, Mackenzie. And yes, if I can invite our previous panelists to come up and join us. Now you get to actually get to ask them all questions. Wait for everybody to get up here. And, oh good, you are still here. I want to make sure, Dr. Bullock, that we still have you. Can you still hear us? Wonderful. Yep. Technology all works. Awesome. And we do have mic around the room, so if you have questions in the room, please raise your hand and we will get to those. The idea of this was to be able to ask everyone who was here questions at the same time, but I want to start with something that I was reading on the way here on the plane last night, which was, it's a book. I had seen an HBR review of it and it looked interesting, so I picked it up. But one of the lines I read just last night was, our social operating system is part of the basic components of who we are as mammals. We are not individuals who learn to be social. We are social beings who have learned to identify as separate selves. And I think at the core of everything we have heard today, we are social beings. We need each other. We need to belong to a group. And I think all we heard were these stories that pointed out the places where we felt like we didn't belong and how that impacted our well-being, to the very clear data that everyone shared to say, no, turns out if you don't feel like you belong, if you feel like you don't belong, you actually are harming your well-being. And now we're sort of in that point of action. So I'm going to take the prerogative of being the moderator of this section and asking the first question to whoever wants to throw it out. What do you want us to do with everything you just said? So what's the action that you hope, as you were preparing your remarks and thinking about it, what was the action you were thinking? I hope that at least someone walks out of this room today to do this. Anyone want to jump in? Go ahead, Jessica.
Go ahead. No, please.
Thanks, guys. I was thinking that it would be something to go home and talk to your administrators of your institutions, have a conversation as high up as you can go, whatever that is, about this work and about what the topics, the discussion, the issues, and how it relates to the bottom line in terms of workforce, dollars and cents, and providing the care to patients. The other thing I was thinking of is that maybe some self-reflection too might be in order, that looking at our own biases and deciding how to manage that in terms of the delivery of care, of how, whether you're helping other people learn how to deliver care or whether you're delivering the care yourself.
I'm going to echo what Dr. Malone just said. So I think I would, so first of all, I'm very hopeful and optimistic, especially when I think of how far we've come based on all the work of NAM and everybody in this room that's sitting here and the inspiring senators and representatives we had earlier today. So I am very hopeful that we don't have to wait a whole nother generation to see change happen. I completely agree with what Dr. Malone just said. I think if folks can go back and make sure that you are measuring how your workforce is doing, if you don't look, you are never going to find it. And if you just stay high level, it's going to be watered down, and you've got to go deep. This is what I think Margot was talking about as well, and Chacha's data showed this too. We are having different experiences, and you're never going to know what those are if you don't go deep into the data. And the other thing I wanted to add is, we have to figure out how to create accountability at many more layers. It can't just be, it will never happen if the senior levels of the organization isn't committed to doing this. And it's a yes and, because if only the senior level is committed to doing this, it will never be scaled, it will never work. So it becomes this, how do we train up the leaders of leaders, the leaders of managers, the leaders of teams, so that they can then help do this work? That'd be mine.
I'll say something. I was going to say it and it feeds well with what she said. putting on the data hat again, other than having data, but also having reporting and public disclosure about it, so that just as right now there's like patient safety measures, you can look at the OSHA recordables for an organization. What if you could see the worker well-being measure of an organization? And then patients can decide, do you want that? Do you want to go to that place? Workers can decide, do you want to go work there? Investors could decide, do they want to invest in that place? So not only having the data, and that would also help with accountability too. So that organizations, you're held accountable for patient safety and you're held accountable for worker well-being. And that is how you're going to know if you get a bonus, how you're performing.
And somehow we're going to do that without adding burden. Of course.
I'd like to, I agree with the panelists. I have just been, again, I'm hopeful after hearing all of the discussion today, all the work that has been done. I shared some things that we're doing at Parkland, but as I stated, we're not there. I mean, we still have a long ways to go. We are actually we're on a journey to be a high reliable organization right now. So that also helps us with feeling comfortable with speaking up. But I want to say is that you may not be able to do these programs that we talked about today, but as Dr. Malone said, just look inside yourself. What is it that you can do from where you stand? You know, you may not be able to do what others are doing, but what can you do? Even if it's the coworkers that you're working with on a daily basis, what can you do to find out how are you doing? It may not be a formal survey, but those types of things would be at the grassroots. And then we will I think, get that message up to the senior leaders. And I do believe, you're right, the organization, the leadership at the top has to be a part of this, and also continuing to advocate outside of the workplace so that others would also see this as an important thing to be working on.
All right, I know we have some questions in the audience.
May I add
so
one? Can I add
sure,
one thing?
please.
I know that I'm.
No, please do speak up.
I think there are 2 points that I want to reemphasize. Is that as we think about well-being, first, that we have a duty to care for our own well-being. And oftentimes we allow, so for my case, I mentioned this whole nights thing. I worked nights because I wanted to sort of be like everyone else, and I didn't want to sort of place more burden on other people. And the end result is that I hurt myself, and I actually ended up out of work for more time. So there's sort of the individual level, like reflecting on well-being and how we can advocate for ourselves, and then the structural level well-being of how we can push systems. And I think in particular, to me, in healthcare, the fact that healthcare is profoundly ableist, to me, it should be deeply morally distressing to us, because our whole job is to care for like illness and prevent illness. And still we do a very poor job both within our own ranks, and there are many ways in which we do it very poorly for patients.
Thank you. I appreciate you sharing that. Sorry, we've got a question in the room. Go ahead. Can you also state who you are when you ask the question?
Sure. Hi, everyone. My name is Javid Sakara. I'm a psychiatrist. I'm the chair of psychiatry at the Institute of Living in Hartford, Connecticut, and part of Hartford Hospital. I came into leadership having been a scholar activist. And what I'm going to ask about is the bridge between data and change. The more complex an organization gets, the more the pressure goes on the people who are the middle managers in the organization. So we love Press Ganey, we disaggregate it, it's great. We look at identity-based disaggregation, we look at leader index, but the pressure often falls on the middle manager, like me, to say, well, your trust score is down this survey, so what are you gonna do? What are your countermeasures? And so I think even in the discourse today, we're talking about leaders, right? We talk about even more senior leaders, but we forget the power that we all have to co-construct well-being. One of the biggest things I've noticed that aligns with some of the data that you've shared is the ability for a leader to have a conversation about well-being is such an essential ingredient. But rarely do we translate the data into how we help leaders actually talk about things that most of us in healthcare have actually explicitly been taught not to talk about. So that's my question. How can we bridge the data on the theme of accountability with tools and training for people to actually leverage the data to make change?
Sure.
Two things on that. Thanks for the question. I feel like I want to say yes, because what you said is really, really important, and it is about training and educating our leaders to be able to use the data and to be able to understand, how do I do this teaching? How do I enable the space to create the safe space, to have this dialogue, to let people be their authentic selves? That doesn't mean be a jerk, but that means like share with me that, you know, you have these challenges, and this is, you know, so I feel like the answer really is use the data, get the training. And I think one of the things that's very clear over the last 3 years is folks have been just trying to keep their heads above water. And we lost a lot of senior level people who decided, I'm going to just be done. And we've moved others up into positions, and we haven't had the chance to train them. So I completely agree with you. I think training is really important, and we see that in our data, that when organizations invest in training their leaders and their managers, they do better. Their engagement scores go up, and the retention of those under them goes up. So it makes a lot of sense to do that.
Anyone else want to jump in on this one?
Yeah, and there is evidence on that. That's the report that Dr. Howard cited, where Leslie Hammer, this researcher in Oregon, has evidence-based strategies for supervisor training, where after the supervisors are trained about how they and the workplace design can impact the well-being of their workers, afterward the workers reported better sleep, better health outcomes, better job satisfaction. So that does exist. It is not something that you have to make up from scratch. There's decades of research on how to do this.
Dr. Malone?
I just want to mention what our keynoter said, something about may not happen in your lifetime. It just might not. But it doesn't mean that you don't stop, because it will happen. And I think that's what, from the keynote address that for this section, that's what I got out of more than anything. You just keep putting the bread in the oven. Somebody else might take it out and even eat it, but your job is keep putting the bread in the oven.
And
I
can
would-
I?
oh, go.
Sorry, you go. No.
No, go on.
So this is from the perspective of the below the leader. I don't know. In my mind, I'm imagining sort of a highway, and I think in most conventional power structures, there is a very sort of linear, singular path to go from A to B to C. I found that in my advocacy work, the most effective sort of leaders and organizations have pathways that sometimes can bypass a B person, because basically if any one person has the power to sort of override or prevent change, you can really cause a ton of damage. And if the people, and it's basically like if the people on the ground don't feel safe, then they sort of inform the next people who come in, and you basically have this perpetuation of unsafety because there was a previous sort of blockage point. And so, yeah, so basically like having leaders who are accessible, who engage like on multiple levels down, I found to be effective.
And I just, to your point, Dr. Bullock, I also like the idea of thinking about how can we engage leaders with frontline workers so they're working in collaboration. When we think about like human-centered design, it really is multi-stakeholder engagement. And, you know, typically there are going to be far few supervisors and leaders. And so while important roles, they're only one. And while it's important, the toll of trying to, you know, change, right course a whole ship in an organization is more than one can bear. And how do we think about this flattened hierarchy where we are all invested and involved in the change we want to see? And what would that look like if people who've been oppressed, you know, or who have been feeling unengaged are a part of the shift that we're all trying to see.
Good afternoon, everyone. My name is Annie. I am from West Virginia, and I work for the Department of Veterans Affairs, and I am a scholarship coordinator for my facility. So my question is, and Dr. Bullock and Dr. Margot, you kind of touched on this, but how would we open up the conversation for DEI without creating that tension or conflict? Because as floor nurses, sometimes we can see that conflict. And the environment that I live and work in, I'm one of many. So I'm the only African-American registered nurse in my department. For my career of 17 years, I've been the only licensed nurse. So how do we open up that conversation to not create tension or cause blame or any type of conflict? Thank you.
So Annie, thanks for your question. That's such an important one. Whenever we hear D&I, I think that people ultimately think race, and it shuts you down, right? Dr. Malone said we all have biases, right, or biases, and so I think a good place to start is that I am a Black woman, I have biases, and to be prepared to discuss those. It's disarming, and it puts us in a shared space. And we can also acknowledge that we're all in different places in this journey, right, to DEI and understanding. And I think the more we say this is uncomfortable, I too share, we have sameness, right? Like here are the things I've had challenges with. Here are my growth spaces. Then it doesn't feel like a us against them. It feels like a we, and we're in this shared community where we are trying to advance these principles for the betterment of ourselves, for the betterment of our patients. And I think that's some of the ways. But I also think acknowledging, like, this is uncomfortable. These are the conversations we have at our own kitchen table. But it doesn't mean I will come to Jessica's kitchen table and talk to with your family about racism, right? And it was really just around COVID and George Floyd that in many communities we said, well, these are the communities I had. These are the conversations I have with my kids, with my young boys. You don't know this. They play together in the playground. You don't know that when we go home, I talk to them about being careful. I talk to them about not wearing their hoodies. And it became more acceptable to have these conversations, but it doesn't mean that they're any less uncomfortable. And now we're in a moment where there's such a backlash against having those very conversations at all. And so it does take a certain level of moral courage and clarity to push back against what we're seeing kind of as this shift away from these conversations, to be able to say, this is the center core, this is the centerpiece of our healthcare profession. We are in the healthcare provision business, and to not have these conversations is actually negligent. And so that's such an important question, Annie. Thank you for raising it.
Yeah, I just want to add a piece to that. And colleague, someone has to say this is a safe place. That I'm going to help make sure it's a safe place to the best of my ability. And part of what Margot's talking about is when you talk about your own biases and that you're human and that it's a human issue. It's not like anything else, but it all belongs to us. That you're creating a safe place for the dialogue. Sometimes you cannot deliver on safety. And that is scary. When those of us who believe that I'm responsible for creating a safe place for these dialogues, Bev Malone didn't deliver. It's one of those mind-shattering, smack yourself in the face kind of things. But the truth is, you pick yourself up and you go at it again. And you try to figure out, how could I have done it differently? This is a journey. It's not a one-time interaction. The other thing I'd say to you, don't do it by yourself. You're the only one there, but everybody else, you could have some colleagues who could take up the issue just the way that you take up the issue of diversity, equity, and inclusion. See if you can't bribe, cajole. Well, me, I think you go at it however you need to. But see what you can do. And colleagues, I'm teasing. But bring along people with you to get colleagues to say, this is not just a Black issue. This is not just my issue. This is about patient care. This is about the way we work with each other. It belongs to all of us.
Absolutely.
Sorry, can I
Dr. Bullock,
squeeze in again?
Sure.
Sorry, I keep squeezing it at the end. I I completely agree with everyone that is talking about the importance of creating safe spaces. I think it's really important to unpack what we mean by safe spaces, because oftentimes people will say it's a safe space to say some things, but it's not safe to say other things, and that can become a very sort of tense sort of topic. Um, because certainly you don't want things to be said that are sort of overtly harmful, but then the judgment is what is considered harmful. And so in particular, I'm going to focus on, I want to comment sort of related to our research. So I basically study identity and safety related to people's identities. And we define identity very broadly. But one of the things that you see across all people, race, with regards like race, ethnicity, gender, sexual orientation, ability status, religion, et cetera, is that people fear being tokenized, which is when they're reduced to some small aspect of their identity as representing their whole identity. You know, I think we often think of tokenization in the form of like, if we only value someone because they speak Spanish when we have a Spanish-speaking patient, that's tokenization. But also when we say terms like, you know, this thing about white men, that's also tokenization. And what ends up happening is we lose the ability to bring a lot of people into conversation because we've tokenized them, or we made statements that show that we don't value them in their entirety. And like in our studies, while every person, you know, we had multiple white men, you know, in our like qualitative studies, but they also have so many other identities. Every person has marginalized identities and identities that are sort of in power. And I think it also requires a lot of personal work to recognize that, yes, I'm a person who identifies as having multiple very marginalized identities, but I'm also a man, I'm also a physician, I'm also born in the US, you know, all these things. I have so many different privileges. And I don't think that everyone always actually holds those things when we talk about fostering safe spaces. And I think we can't hold the sort of breadth or depth of people unless we have done that work first.
Absolutely. Dr.
Hi,
Villanueva?
my name is Rachel Villanueva. I'm an OBGYN in New York, and I'm the past president of the National Medical Association, representing Black physicians across the country. And NMA was born in the Jim Crow era. And I think for me, as a past president representing a group of physicians that has not increased its numbers in 40 years, we don't have a safe space anymore to discuss diversity, because the Supreme Court has dismantled that. And so my question is, at a systems level, how do we affect the change that we are going to need to make the changes that we need for our workers and for our patients? Because as Dr. Brooks Carthen so nicely outlined, there's very little data about advanced practitioners. There's very little to no data about physicians of color. And so, but we know that the stories are there. I don't really need the data, actually. I mean, we do need the data, I'm sorry. I'm so sorry, I didn't say that. We can erase that. We do need the data. But really, I don't see how we are going to make the change now at a time when these systems are not held accountable anymore. Because we didn't do much when they were held accountable. And so how do we affect the change now that there is not that accountability anymore?
Okay, thank you. Great question. I would actually say, like, we have to do this. We can't afford not to, because things are bad right now. Like, we have, and I'm going to shift this a little bit. So every one of our organizations I know is very anxious financially right now, right? And you have CFOs who are worrying about, like, financial capital. I can't imagine there's anybody who is not worried about that. I think we have made progress, even though we still have a long way to go on, like, individual human capital. Like we talked about it, right? You have to take care of yourself first. We're not great at this, but we're way better than we were 20 years ago, even though we still have a long way to go. But this is going to bring me back to what Elisa said at the beginning with her quote from her HBR book. which is about social capital. And at the end of the day, like, that is the only way we are going to win right now, is figuring out how do we work better in teams? How do we leverage every single last one of us so that we can be better, stronger, faster with what we've got? Because, like, we have nothing left. Like, that is the one area that we have got to figure out better. So I hear what you said, and I agree with that incredible challenge that we're facing. And look at the incredible people in this room. Think about the people that we at least do have on board. How do we create the spaces to have these dialogues so that people do feel more safe? It is on us to have these, to not wait another generation. I am more hopeful. I hope. I mean, I loved Tiffany Wright. I think that was her. Oh my gosh, I loved everything that she said. And I want this to change in this generation, and not, I agree with you, keep baking the bread and all of that, but like, let's like make sure we're doing something with the bread, so.
That's right.
Mm-hmm. So I hear your concern and your alarm and your right to be concerned and alarmed. I hear Jessica's hope, because we know hopelessness is a tool of the oppressor. We're not the first generation to experience a backlash against diversity and equity inclusivity. And so if we look historically, we know there's precedent for that. And so when the pendulum swings, we have to expect that it will swing back, right? But we have to be strategic. We have to be well armed. We have to go in different directions, right? So it doesn't mean we stop, but it means we pivot and we move differently. And so we know that we have the power to be strategic. When I think about Harriet Tubman, right? We have the power to be strategic, and we have the power to be covert. And so I would challenge us to think creatively, strategically, and tactically, and not to take our foot off the gas.
Absolutely. I know we've got a couple more questions here, so want to get a chance to get them
Yep. Go ahead.
right here, and then
Jerry
we'll come
Abraham,
up with the
president
chief.
of the Los Angeles County Medical Association, and I work at a historically black institution, which is also an acute psychiatric hospital, Kedron in South LA. And I'm also faculty at Charles Drew University Historically Black Medical School, the fourth in the nation, along with Meharry, Howard, and Morehouse. And really appreciate everything that y'all have said. In fact, y'all are amazing, so thank you for all that you've shared and imparted of your wisdom, honestly, and experiences, so thank you for that. And thank you for all the work you do with data, too, because I think you're right. We do have to tell the truth. And just, I want to build off of what Dr. Villanueva kind of was asking. There are experts, and we need to make sure that they are in the room. And that's something that I want to continue to encourage. I think when we think about what are our next steps, we do know there are black and Latino leaders that are in this space. And there is data that shows historically black medical schools produce a diverse workforce. And we should be building and strengthening upon that. But I would say one thing, just to impart to the room, is who is missing in the room, who's missing from the conversation, I feel like is a big part of what we've got to talk about. And then if we're trying to solve a problem and folks are not in the room, then how are we going to really get there? And those folks really need to be a part of the conversation. And so I just was curious what y'all's perspective on how do we bring black and Latino leaders to these conversations and make sure that those institutions that are best practices for hiring minority health professionals, how do we spread some of those lessons throughout into other systems? So thank you.
Can I?
Yeah.
Oh, go ahead, Dr.
Yeah, I just want to say I think we invade the boardrooms because a lot of decisions about who gets at the table are made in boardrooms. One time a gentleman asked me, he was going into a board meeting, he said, "Bev, you always got great ideas. Is there anything you want me to take into the boardroom?" I said, "Yeah, tell him save me a seat."
And then I would say pull someone in with you, right? So I'm here because she was there, and she was at A&T at HBCU. I was her student, and she said, "You are the future of nursing," and I dared believe her, right? And so who are you inspiring? Who are you pulling in the room? Whose name are you saying when they're not there? That's our responsibility. I'm here because someone gave my name to NAM and said, "You have to be on this panel." So they thought of me. They weren't a person of color. They saw me at another meeting, and they invited me to the room. So now I just showed you that picture of Shine. I did that on purpose. I wanted you all to know it's a lot of people out there who share this passion. We need to get them in the room. They need to be part of the data collection and the intervention development.
Dr. Bullock, I know you were trying to jump in there.
Yeah, thank you. I want to I guess, do a little bit of a shameless self plug for our work. I work with Dr. Sakira, who I know is in the room, on identity safety. Referencing the person who spoke 2 people ago, I guess I would sort of gently challenge the fact that I think that there is a lot of safety that exists, and that people have found ways to create their own safety, but we haven't sort of recognized it, because a lot of the research that we do really focuses on the harms or the challenges that people face, and we don't actually take a lens looking at safety. One specific aspect of identity safety that I want to highlight is something that comes out very clearly, is that people can foster their own safety when they draw on their identities to serve patients. And this is something that people have done since, forever. But it's not something that we often talk about within medicine. And what I find with our participants in interviews is they often feel very oppressed by like professionalism norms and how they have to behave. But then when they're in closed room with patients, they can act differently, talk differently. They can relate to patients culturally. They draw on their own lived experience to actually heal people. And this is one way that people create power and safety for themselves. And I think that's how a lot of people exist in very toxic situations for a long time. And not that that should make us feel sort of complacent, but to recognize that if we had more stories about the power that people bring, we know that there's improved primary care screening when you have like race concordance and language concordance and all these things, but we actually don't really know why or what is happening. And so I would say that's an area that I'm interested in, and I think that there's a lot of potential research, potentially very powerful research and not even from a perspective to validate why minorities should exist, but really to empower the fact that we are making very meaningful, positive impacts in the care of our patients.
Absolutely. I think we've got time for maybe 1 or 2 more questions. Carol?
Yeah, I'm Carol Bernstein. I'm Vice Chair for Faculty Development and Wellbeing in Psychiatry at the Albert Einstein College of Medicine and Montefiore Medical Center. And I just want to say one quick thing. I want to thank Dr. Malone, who I've known for a long time. This is a long haul, but I've been in it since 2013 when we kind of started this big journey way back at the ACGME, as Tim knows, and we have come a long way. So I want to say that, I think we need the perspective, even though this is a tough time, and we've been through tough times. And the second thing is, we have to use this room. We're not going to answer all the questions today. We're not going to have all the solutions, but there are tremendous resources, and I hope that each of us will continue to work with each other, because it is a long haul, and we're going to get burned out and upset if we don't support each other in this. So,
Absolutely. We had one more. You're going to make me choose? We have time for both of them then. You're just all going to hang on. Please give Dr. Golden the last word.
Hi, I'm Sue Sheridan. I'm bringing a different perspective. We're talking about everybody needs to be in the room, everybody who's passionate. I'm a co-founder of Patients for Patient Safety US. We're a chapter of WHO's Global Network of Patients dedicated to safe care. And we've kind of brought that up periodically, that without clinician well-being, there's no safe care. And I really want to focus on that. And today, ECRI, who puts out their list every year of the top 10 patient safety challenges, guess what's number 5? This came out today. Number 5 is decline in physical and emotional well-being of healthcare workers, is number 5 in patient safety risk. So I want to share that there's a big community of patients, consumer organizations, community organizations that want exactly what you want. So we need to be part of what you're doing, because we're actually very good here on the Hill. We can go to our congressmen and senators. Guess what? We can't get fired. We can't lose our job. And so we can be your voice in demanding clinician well-being for our safety and better outcomes. So I want to see next year when we do this, I want to see a panel of patient organizations of chronic illness, of patient safety, of caregivers to say, we're here to demand well-being for this community because we want to be safe.
and we as healthcare providers are a part of that community too.
Absolutely. Yeah, I just had a comment, and I just wanted to echo what Dr. Brooks Carthen said about the way in which we have to move strategically at different times. So, you know, I often have said, you know, to those I've worked with, that there are times where you have to be like Martin Luther King Jr. and Rosa Parks, and you're out marching in Washington with the banners up, but there was a reason that Harriet Tubman's Railroad was underground. And there are times where you have to do things, as you mentioned, covertly, like you're changing your policy, like you're putting things in place so that even if they kind of revolt against you, like the changes have actually already been made and they're built into the system. So I think we have to think about how are we changing the systems to be more equitable and inclusive, because a lot of that is much more subtle. And so I think that we've got to be able to figure out how to navigate back and forth between the two to bring about the change we need.
Absolutely. All right. Well, on that note, I'm not going to top that. And look at that. I am on time on. I want credit for that. You all have earned a very, very well-deserved break. I know you have been in those chairs for a while. Please grab a snack. We'll be back here in 15 minutes.